Sir, we are live now. You can start. Thank you.
Okay, thank you.
Hello, my name is Dr. Kirtidas Joshi and I am presenting long case today. Eight-year-old boy, first by birth order, born out of third-degree consanguineous marriage, resident of Parbhani, Muslim by religion, brought by parents, came with chief complaints of fever 2 days back, vomiting since 2 days, decreased urine output since 2 days, periorbital swelling since 1 day, pedal edema since 1 day, and decreased oral intake since 1 day. Fever was undocumented, low grade, not associated with fever or chills, not associated with rash or chills. Vomiting was 2 to 3 episodes per day, small in quantity, containing food particles, not containing blood in vomitus. Periorbital edema present throughout the day but more in the morning. Pedal edema also noticed by the mother approximately till ankle, present throughout the day. Child used to pass urine 6 to 7. Child used to pass urine 6 to 7 times a day before, but currently passing 2 to 3 times a day, small in quantity. For fever, child has taken some Ayurvedic medication from outside. Child has significant past history. Child was admitted 1 year back in outside hospital, 1 year back, approximately for 1 month, for abdominal pain, increased paleness, and decreased urine output and pedal edema. History of Ayurvedic medication intake was present before admission, after which the complaint started. Child underwent 6 cycles of hemodialysis at that time, received red and white blood products. Parents were told that child has raised blood pressure and medications for the same were given. Gradually, the distension improved, urine output increased, blood pressure normalized, and child was discharged on some oral medication, which was stopped after 1 month, and then child was lost to follow-up. In last 1 year, child was eating well and passing urine daily 4 to 5 times a day. Currently, there is history of pruritus since 2 days, history of irritability present since 2 days, no history of hematuria, no history of burning micturition, no history of loose stools, no history of cough cold, no history of hearing loss in child or parents, no history of rash, joint pain, no history of not gaining weight or height compared to the peer group. Antenatal history is uneventful. Birth history is full term, delivered by vaginal delivery, cried immediately after birth, and birth weight mother does not remember, no history of NICU stay. Developmental child has achieved all the age appropriate milestones on time, and child currently has good scholastic performance. Child is immunized till date. Dietary history is also good. Expected calorie intake is 1,500 kilocalorie, and child's current intake is 1,250 kilocalorie with deficit of 250 kilocalorie. Expected protein intake of 30 gram with current intake of 24 grams and deficits of 6 grams. Socioeconomic history, the child is first by birth order and there is no similar complaints in siblings and belongs to lower middle class according to modified Kupus-Comi scale.
Okay, so now let's take the presenting complaints this time. So you said there's fever for 2 days. We'll go to the details. So fever for 2 days, undocumented, low grade, and getting relieved on medication, not associated with rash or chills. So one is that all this description that we give for every fever, no, we should have a meaning behind it. So when we say low grade fever, are you likely to get chills? You're not likely to get chills, right? So you should not include chills in the description if it is a low grade fever. So this is low grade fever and undocumented. So you can't make out anything out of it. Suppose it was documented and there is genuine fever, means because it's undocumented, we don't even know whether there was fever or no. But suppose it was genuine fever, what would be your interpretation of a low-grade fever of 2 days? Means what can it be? Hold on. On a
Hello. It can be some underlying infection.
Correct. That's what we mostly think whenever there's fever. We think it's an infection. Now, what kind of infection? Viral or bacterial?
Viral infection. Since
So low-grade fever sometimes may be a low-grade viral infection. Bacterial infection usually is high-grade fever. So we will think either this is not, fever is not important, or it is maybe a low-grade viral infection, right? Now, vomiting 2-3 episodes per day in small quantity containing food particles, not containing blood. So again, one thing is, why did you specify not containing blood? Means, are we thinking of something?
not severe retching or is there any tear.
So in other words, you will bring in that blood or no blood if there are 8 to 10 vomits. In 2-3 vomits, you don't expect blood, right? So unless your previous history suggests that you're expecting blood, not containing blood is not necessary, right? But for every vomiting, what are we trying to do? We are trying to decide the anatomy. Where is the vomiting coming from? So for every vomiting, bilious, non-bilious is important because it tells you the cutoff in the intestinal tract, right? So you would say this is non-bilious. Now 2 to 3 vomits would mean what? Interpretation would be what? So my question is it GI tract in origin, or is it hepatic in origin? Is it renal in origin? Is it CNS in origin? How will you make it out?
2 to 3 most likely to be GI related.
How many times does a child with jaundice vomit? Is it a rule that he vomits more? What I mean is that 2 to 3 is a very non-specific number. It doesn't tell you anything. But how do you decide on any vomit, whether it is GI or non-GI? Some one or two thoughts.
If it is related food intake, after food intake or related to nausea.
So even a hepatitis person, as soon as you force him to eat, he will vomit. So it is related to food. But the origin is hepatitis, not GI. By GI, I mean esophagus, stomach, intestine. So which is the commonest cause of esophagus, stomach vomiting, which you know of?
GERD gastritis.
So gastritis and, okay, GERD. So GERD has only vomiting, nothing else. It is over a long period. Short illness, what is the commonest cause? Even gastritis is a, how often do you see gastritis in children? It has to be drug induced or there has to be a reason. So gastroenteritis is the commonest reason for vomiting in children. In that, when is the vomiting in the whole illness start? So that is the most important point. So when vomiting is in the beginning of the illness, it is highly likely to be local, esophagus, stomach, etc. And if vomiting is later in the illness, then it may be other organs. So it could be hepatitis, CNS, whatever. Understood? So now here we've not made out much out of the fever, not made out much out of the vomit. And then periorbital swelling throughout the day, but more in the morning. So now what does that tell you? Commonly periorbital swelling tells you what?
Mostly it is renal origin.
Mostly it is renal in origin. Okay, and what is happening at the renal level? Proteinuria is happening. Okay. So now you are assuming that this is going to be a proteinuria of renal origin. Pedal edema noticed by the mother, present throughout the day. This came up in how many days after the periorbital edema? Same day. So within 1 day. Okay. Earlier child used to pass 6-7 times urine, currently passing 2-3 times. So for fever, child was taking some Ayurvedic medicine from outside. So now, after a short febrile illness, which you don't know what it was, and some 2-3 vomits, which also you can't make out much, you've got periorbital puffiness and edema. So what do you think? This is nephrotic syndrome based on this history? Based on this history, you still don't know the past history.
Age group is not matching with the nephrotic.
What is the age?
8-year-old.
Very good. So 8-year-old is slightly higher for nephrotic syndrome. Okay. So one question mark in your mind, is it nephrotic only? Right? Secondly, if you have seen many nephrotics, when they start with periorbital edema, do they get edema all over the body in 1 day only? Takes how many days?
At least 3 to 4 days.
2-3 days, 4 days, slowly progressive. So that is the other point that you are noticing. That's not like it's a very make or break point, but you are noticing some difference that, oh, suddenly developed edema all over, right? So this suddenly developing edema all over might make you suspect whether this is a prior original problem was there already, and this fever has just served to trigger it off, right? If it was a first time nephrotic syndrome, our usual classical story is different, age is different, right? Okay.
Yeah, the history alerts you that though apparently it looks like something which has come up in 2 days, we should be more aware that this is not likely to be 2 days. 2 days puffiness and edema also. That means the hypoalbuminemia has come up in such a short time, and vomiting right at the onset of vomiting. That means the biochemical changes have been, it is biochemical in origin most probably, and have been there all along. Nausea has been there just at that time. So the biochemical changes have occurred, maybe uremia, and this is so. The history is not a straightforward history of something going on in this particular child for a long time. Maybe from what time we don't know. There is no history suggestive of hypertension, though if there was some headache or anything, we would have kept that in mind. Though headache and vomiting does mean whether it is CNS, but then pedal edema, etc., is less high. So chronic illness in an 8-year-old child, glomerular disease associated with significant hypoalbuminemia, there is likely to be biochemical changes in the form of high urea, creatinine, etc., though we do not know. And we don't know the past history. UTI as a common cause of dialysis in older children, missed UTI. He's little too young for that missed UTIs coming for dialysis. So some glomerular disease coming on from early life. Nephrotic syndromes coming and resistant also. Perhaps at 8 years going to this particular was perhaps a little too soon. We keep on giving steroid and they don't respond, etc. Well, 13, 14, they're really bad, but there's no rule. So some glomerular disease coming on from early life, and then we may just scratch our and say third-degree consanguine. Sometimes it is helpful, sometimes it is not. It's always better to take that in mind, and therefore any genetic disease which has been present earlier. We don't know the past, but past is, we have assumed that past is bound to be sick. So we keep a genetic disorder also, glomerulopathy, chronic renal disease, and now he's presenting like hypertension is expected, high urea is expected, polyuria is expected, but that will.
This time's fever and vomiting, can it be UTI? This time. This time there was mild fever, no, which was undocumented, low grade fever and vomiting and then edema. So can this be UTI? So one is high grade fever. Two,
No urinary complaints.
do you need urinary complaints in UTI? In an infant, you don't get urinary complaints.
In 8-year-old, there are usually.
Very good. So infant will come as a sepsis-like picture. So high fever could be vomiting of toxemia, okay, and no localization. But older children will come with local symptoms. So even if it is upper UTI in an older child, upper, what is the immediate thought that will come to your mind? They should have a past history. You can't have a first time pyelonephritis at 8, 10 years of age in an older child. And if it is lower UTI, then there will be complaints of burning and all that, right? And lastly, can you get edema in UTI, generalized edema? Why not? You're right, but give a very solid answer.
There is no proteinuria and glomerular involvement.
So UTI is not a glomerular involvement. UTI is a collecting system involvement, whereas proteinuria is a feature of glomerular involvement. So because UTI is not a glomerular, what do you call it? Pyelonephritis. So pyelo is what? The collecting system, the calysis, right? So it is not glomerulonephritis when you have UTI. So UTI is not glomerular disease. That's why no proteinuria. That's why no edema in UTI, right? Okay, now we go to the past history. So 1 year back, the child was admitted for 1 month for abdominal pain, increasing paleness, and decreased urine output and pedal edema. So Ayurvedic medications, okay, and dialysis. So now, what would you have thought of with these complaints at that time? 1 month of abdominal pain, increased paleness, and decreased urine output. That time, how would you have approached this problem?
So since there is, at that time also there were acute complaints only. He was admitted for 1 month, but complaints were for 2 to 3 days only.
To begin with,
Good.
2-3 days of abdominal pain and paleness. So then the paleness happened over 2-3 days only.
Not noticed it before, but yes, according to the mother.
What would that make you think?
Some hemolysis on.
Very good. So if that history is correct and you've extracted the history properly, then a sudden appearance of paleness would suggest hemolysis. Could also be seen in a bone marrow problem, but then it's not that sudden, but yeah, 5, 7 days, 10 days. But then you would see petechial spots also. So history of petechial spots that time, no. So you think of hemolysis. Now, if hemolysis is accompanied with decreased urine output, then what would you think of?
HUS.
One is HUS, what else?
SLE. Lupus.
So lupus, as in you are saying that one disease, one involvement is hemolysis, one involvement is kidney involvement. But I am saying, can hemolysis lead to a kidney problem besides HUS? What happens in intravascular hemolysis? You get a lot of hemoglobinuria and cola colored urine, no? So you may get some affection of glomerular filtration in those situations, right? Okay. Then, so 2-3 days abdominal pain. What would that mean? What else could it be? Don't get stuck to HUS. You are right. HUS is one possibility, but think more. A child comes with severe abdominal pain and his urine output has gone down. What else can it be? Okay, sickle crisis. Then what happens in renal vein thrombosis? Okay, and it's an important complication of nephrotics. So whenever a nephrotic comes with severe pain, one you think of is, what do you think of? Renal vein thrombosis second. Before that, what do you think of? SBP, right? Okay. So the child went 6 cycles of dialysis. That means this child was in renal failure. Okay. Then received red and white blood products. That means must have received plasma and fat cells. Okay. So for hemolysis. So the child had raised BP also. Fine. Okay. So that was an episode of HUS probably. And then the child has lost to follow up and has come now. So now in this history, with this history, what do you think now could be the possibility with this past history?
AKI on CKD, existing CKD it can be.
Okay, but how does the current history suggest AKI? Current history is 1 day of non-specific fever, 2-3 vomits, and edema. So does that decrease urine output? Okay, I mean, if it's very accurate, it may suggest oliguria and reduced GFR. But what about the edema? Does that suggest AKI this time? So has he had edema any time in the past?
Last 1 year, no.
Prior to that?
In last admission,
Prior to that?
no.
Last admission was his first illness. Yeah. So what I'm trying to say is that just now, if there is AKI for any reason, acute kidney injury, what will that do? It will affect the glomerular filtration. So your urine output will fall down, right? But if it causes proteinuria, that means there has been chronic damage already all over, I mean, over time, right? So the pedal edema today doesn't suggest kidney injury today. It probably suggests chronic damage over time, right? What is the difference in edema of your post-streptococcal glomerulonephritis and your nephrotic syndrome? What's the difference in edema? Clinically, what is the difference in the edema of these two situations? Post-streptococcal glomerulonephritis and nephrotic syndrome. In glomerulonephritis, edema is mild. Nephrotic syndrome, edema is massive. What we are learning is that when edema is due to reduced GFR and fluid retention in the body, when that is the mechanism, a GFR is low, so retention, the edema is mild. But when the mechanism is proteinuria and hypoproteinemia, the edema is massive, right? So this time you are saying that he's got puffiness of eyes and edema feet. This much edema just due to reduced GFR is less likely. That means there is proteinuria also. That means there has been damage over this last 1 year leading to proteinuria. You understood what I'm trying to say? Okay.
I couldn't read it. So, assuming that this child had acute pallor and something suggestive of HUS then, and we have seen many HUS, but most of them that we see the acute HUSs, they are secondary to gastroenteritis. And the child, usually small children, I had a series of 20 acute HUS following Shigella. But that was in 1978. There was an epidemic. So usually acute GI infection and HUS is common in small. There's something called atypical HUS, and they present later, and they may present acutely. They improve, you think, oh, well, they have improved. They have never. And one of the causes, if you go to see the dialysis center, one of the causes of adolescent children coming for dialysis repeatedly are those who have atypical HUS with significant hypertension, pallor, and the edema doesn't dominate so much as hypertension in this. So if this was HUS then maybe this particular child has atypical HUS and he has not. What could have been the other cause at that time? I think sudden pallor and edema at that time was HUS. That's the thing. Can we use genetics here? Because I brought in the point of consanguinity. One does not know that. I don't know whether there is any genetic predisposition in atypical HUS. I have only seen 2 atypical HUS. Both were boys of this age, but I don't remember whether they had any. So mostly atypical HUS that we are dealing with.
Okay. Now, in the last one day, 1 month, 1 year, child was eating well, passing urine 4-5 times day. History of pruritus since last 2 days. What does that mean? What could it be?
Increased uremia.
Okay, it could be uremia. And then you are corroborating it with irritability since last 2 days. So that goes hand in hand, that there is some metabolic disturbance happening. It's a big child, no? 10-year-old child, right? Okay. 8-year-old, 10, 8. Okay. Fine. And then there is nothing else in the history. Otherwise, nutrition, everything. So now here again, as we always say, was this child absolutely all right? So all this happening in one day seems less likely. So whether there was a build-up happening before these 2-3 days of symptoms. So we need to ask whether he was absolutely all right before these 2-3 days. According to her, she was, or you didn't ask? Or
Did ask. According to the mother, child was fine 2 days before.
fine. Fine, come now.
Summary: 8-year-old boy, first by birth order, born out of third-degree consanguineous marriage, with complaints of fever, vomiting, decreased urine output since 2 days, and periorbital and pedal edema since 1 day, with history of similar complaints in past with hypertension and edema, and requirement of hemodialysis with history of Ayurvedic medication intake in a developmentally appropriate and fully immunized child, is probably a case of AKI, probably RPGN, my differentials being atypical HUS, vasculitis, and lupus nephritis.
One is that on what basis can we clinically say RPGN? Any reason you said that?
Progression is very fast. I think. fever and edema came in 2 days.
This time ka. So the point is, see, this time ka progression very fast, as I just discussed, that it is doubtful that this time ka thing is only glomerulonephritis. There has to be an underlying damage, I feel. One. Second, if this time's presentation is glomerulonephritis, there has to be hematuria on history, no? Gross hematuria. That is not there. So what I'm trying to say is, what I would think is that if a patient came to us with a clinical presentation of what looks like acute post-streptococcal glomerulonephritis, classic, which means high colored urine, some symptoms related to hypertension plus minus, and mild puffiness of eyes. If a child comes with that, and then this child rapidly progresses, you may call it rapidly progressive glomerulonephritis clinically. You're getting what I'm saying? Our history is not of a glomerulonephritis. It is of a kidney damage on a pre-existing problem. Today's episode is difficult to be called glomerulonephritis on the basis of low-grade fever and 2 vomits and edema all over. You're getting what I'm saying? So that is one. Second is, what is the importance of that Ayurvedic medicine? You mentioned it earlier also. So what is the importance in this such a story?
It is renal toxic. Just toxin in the renal engine.
He said it could be renal toxic. So you're right, but take it further. Why is Ayurvedic medicine renal toxic? It contains what?
It contains mercury.
Mercury, silver, lead, so heavy metals. So that is why if taken over a long time, this could be potentially toxic.
For us.
So now you said my differentials are either atypical HUS. So what is atypical? Means what is typical HUS and what is atypical HUS?
In typical HUS, there is usually history of loose stools prior to the event, and age group is not, which comes earlier in the life.
Very good. So that's typical, and when that history is not there, you call it atypical. And the causes of atypical are usually something else. They are not the following that Shiga toxin and all that. Then you said vasculitis. So means explain why vasculitis you are saying. And third is lupus nephritis, which is almost similar. So why are you saying that? You may be right, but why are you saying? Justify.
Because there is history of hypertension and similar complaints in the past, and there is history of consanguinity also.
But the previous episode history is very suggestive of HUS. So then why vasculitis?
I would like to rule out vasculitis.
So actually you are right. So the answer is that once you move away from infection related HUS, your typical Shiga toxin related, in the non-infection related HUS, one of the causes is autoimmune disorders. So your vasculitis or your SLE can also cause HUS, atypical HUS. So in atypical HUS, what sir was saying, genetic, and then these autoimmune disorders, everything comes in. There's a big list of atypical what can cause. So that is why that stands. So atypical HUS is just the clinical presentation of this illness or this clinical entity. But what is behind the atypical HUS? Is it a genetic cause? Is it autoimmune? Is it SLE? We don't know. So therefore, that still stands. Okay, fine. Come.
Sir, actually, the child is in dialysis currently, so we could not get him here. So on examination, child was afebrile with pulse rate of 135 per minute, good volume, normal rhythm, no radio or radioephemeral delay, respiratory rate of 22 per minute, saturation maintained, peripheral pulses were well felt, extremities warm, and BP was maintained between 58 to 98 centile. On anthropometry, weight is 20.5 kg, 102 by 68. Weight 20.5 kg, which lies between -2 to -1 standard deviation. Height 128 centimeter, which lies between 0 to 1 standard deviation. And BMI is 12.5, which is -3 to -2 standard deviation. My impression is thin. On head-to-toe examination, pallor was present, scratch marks due to the itching present, periorbital and facial puffiness was present, and pedal edema present up to the ankle, pittering type. On systemic examination, on per abdo examination, it was non-distended, no dilated veins, scars or sinuses. Hernial orifices were normal. On palpation, soft, non-tender, no organomegaly. On percussion, tympanic note was present, and on auscultation, bowel sounds were present. On CNS examination, child was irritable but oriented to time, place, and person. Tone power reflexes were normal and no signs of raised ICT. On CVS examination, S1, S2 was present and no murmur. Air entry was bilateral equal, clear. On head-to-toe examination, there were positive things. Pallor was present, and scratch marks suggestive of uremia, and periorbital and facial puffiness, and pitting time of edema, which was suggestive of renal origin, and all. Height was good. Height is good. So 128. -2 to -1, which is also good. Less likely chronic, not very long standing.
See, you have to learn to analyze these things properly. So, one is his height is good, right? And as per your history, he did not have any complaints 1 year back before that. So his whole illness as per history spans for 1 year only, right? He is now 8 year old, correct? So that means 1 year back he was 7 year old. Normally a 7 to 8 year old, 1 year, how much height they will gain? No, in that 1 year, 5 to 6 centimeters. So what I am trying to arrive is that this 20 kg, which is a little lower compared to the height, it may have been 23 or 24 kg 1 year back, no? So it is not yet time for his height to start getting affected to call it chronic. That much time has not passed. Means in 1 year, first of all, his height will stop get growing after 6 months, 9 months. And in that period, it will grow 1 or 2 centimeters. So that he has not grown 1 or 2 centimeters is so difficult to judge unless you have last year ka exact reading. You understand? What I'm trying to say is when you have such a disparity, this could be constitutional only. He could be thin forever. But it could also be that he was better and he has lost weight in this 1 year as the first marker of a chronic illness. You understand? So that you need to cross check with the parents. Secondly, there was a question from online. What is the reason for tachycardia, you think?
Child was anemic when he came.
That means significant anemia. If it's causing tachycardia, then it is significant anemia. Okay, fine.
Done. And whether he was going for CCF or left ventricular, but he was not, surprisingly, he was not hypertensive at all.
So again, what I'm trying to, why I asked you what we got positive on on examination is, so you've got scratch marks and you've got edema and you've got pallor, right? So how will all this equate to your final impression that we need to analyze? They're asking, was he on antihypertensives? He was, no?
In previous admission, yes, but he stopped all antihypertensive.
He stopped, but he was told to take last year. Yeah, fine. So now you construct your final diagnosis.
Can be, but mostly present in females, and in males it's present with more sickness. Child should be more sick than he is. A rash and joint pain. Summary is 8-year-old boy born out of third-degree consanguineous marriage with history of similar complaints with history of hemodialysis and hypertension and edema in past. Developmentally appropriate and fully immunized child is a case of AKI with uremia, most likely atypical HUS. So these are the investigations done in past admission 1 year back. The child's HB was 5.8, WBC was 10,900, platelets 38,000, MCV was 98, MCH of 31, MCHC of 31.8. On PS, there was histiocytes seen and leptomalaria and dengue rapid tests were negative at that time. On RFT, urea was 241 and creatinine was 9.6. CRP was 2.1 and blood culture and urine culture showed no growth. On this, child received 2 PRC and plasma transfusion and 6 cycles of hemodialysis in last admission, and child was lost to follow after that. In the current admission, child came with HB of 6.1 to us, hematocrit of 21, WBC of 9,300, platelets of 56,000, MCV of 80, MCH of 25, and MCHC of 36. PS showed histiocyte seen and retic was 6.1 on arrival. After 1 dialysis and 1 plasmapheresis and 1 PRC transfusion during dialysis, HB was 6.5, hematocrit of 17.8, and WBC count 9,700. Platelets increased to 1,19,000. MCV and MCH was same, and still PS is suggestive of histiocytes. RFT on admission was BUN of 123 and creatinine of 5, which has decreased to 74 BUN and creatinine 3.9 now. DCT and ICT were negative. Urine RM was suggestive of 15 to 20 RBCs and 3 to 4 pus cells, protein 2 plus present. C3, C4 levels were normal. And anti-factor H antibody we did, which showed 5,500, which is highly positive and suggestive of atypical HUS.
So why is the retic count high?
Rajesh sir, sorry to disturb you. Can it be a little bit louder?
Yeah, okay.
Yeah, thank you.
Why was the retic count high?
Outside hemolysis going on, so marrow is proliferating.
So if you get a retic of 6.1%, let me ask you the other way. How will you interpret this retic? So first question is, suppose somebody has a hemoglobin of 6 and a retic of 6. Does it mean it is iron deficient, or does it mean it is hemolytic anemia?
We'll have to calculate corrected retic count first and see if it is high.
Very good. So first step is corrected retic count. And if it is still high, it means hemolysis. Correct? Now in this child, where is the hemolysis happening? As in, it's not a congenital hemolytic anemia, right? Hemolysis is, where is it happening?
Extravascular hemolysis.
Yeah, but where? In the spleen? Like all hereditary spherocytosis, this, that. Any thoughts? So what is the word used in HUS? Before hemolytic, what is the word?
Microangiopathic hemolysis.
What does that word mean? Microangiopathic means what?
Small blood vessel.
So hemolysis is happening in the small blood vessels. Okay. So what is schistocytes?
Fragmented RBCs.
What fragmented means?
Destruction.
Broken. So these RBCs, while traveling through those small blood vessels, they are actually put under so much pressure that they break. So what is also there in those small blood vessels? Normally in small blood vessels, RBCs circulate, no? Itna bhi small blood vessel hone do. RBCs circulate, blood is circulating in the smallest of capillaries. So what is the problem here? So why have the platelets gone down? Are they also being destroyed? So there are lot of thrombi in those micro circulation. So ecto circulation is micro. On top of that, many small micro thrombi where all the platelets are getting used up. So that is making it a very rough passage. And that is why the RBCs are breaking down. And that is why a hemolysis, right? You've done a LDH, you expect it to be high.
Is 5,500. Yes.
LDH is 5,500. Very good.
Hemolysis.
And and what is this factor H antibody? Explain that.
Done for breast.
So there are these genetic HUS has lot of complement related issues, and there are many genes and all which cause all these complement related problems, as a result of which you get this whole problem of microangiopathy, right? Okay, fine. How will you treat him?
Plasmapheresis and hemodialysis.
So with that, what are we expecting to achieve?
Decrease BUN and create first. And PRC transfusion to build up the HB. And finally the steroids. Child will require steroids for the treatment of HUS.
Correct. So for the so-called autoimmune process, all this dialysis and all is not. This is just to restore kidney function. So this is all supportive treatment. This is not curing the cause of the problem, right? Fine. And any other treatment has been tried in such cases? Maybe not in this case. Nowadays, there are monoclonal antibodies, okay, which are used against that complement. Obviously, we don't know which cases to use and all, but there are monoclonal antibodies being used, right?
Renal transplant? Why not? Yeah, the biochemistry may repeat, and even the transplanted kidney may have to undergo the same prognosis.
Yes, Yesha Prajapati has answered Eculizumab. So that's the name of the monoclonal antibody. Of course, which cases to use and not is a specialist's domain, but yes, you're right. Okay, any other questions or comments from the online audience? Okay, thank you, Anjali. So we now move to the next case.
Three-year, 5-month-old boy, second by birth order, born out of non-consensual marriage, hailing from Wada, resident at Wada, Hindu by religion, Vani by community, informant being mother, presented with chief complaints of abdominal swelling at 6 months of age. Since 6 months of age, child was apparently alright till 6 months of age when mother notices abdominal swelling on upper left side of the abdomen, insidious in onset, gradually progressive, not associated with diurnal variation, not associated with pain, no aggravating or relieving factor, progress to abdominal distension. No history of fever, no history of jaundice, no history of blood transfusion in the past, no history of blood in vomitus, melena, or any other bleeding manifestation, no history of vomiting, no history of loose stool, no history of pedal edema, no history of gallstones in the family, no history of weight loss, bone pain, no similar history in family, no history of altered sensorium, lethargy, irritability. For above mentioned complaint, child was admitted in some private hospital from 21st April to 27th April. Some tests are done, and treated for dengue and discharged and asked for follow-up. ANC wise, no history of known comorbidities, no history of fever with rash. ANC scans done normal. Iron and folic acid supplements taken. Birth history, full term normal vaginal delivery, birth weight 3.5 kg, baby cried immediately after birth, no history of an ICU stay, no history of neonatal jaundice, normal perinatal events, no history of any unexplained weakness, no history of umbilical catheterization, no history of neonatal sepsis, immunization till date. Developmentally, climbs upstairs and downstairs with 2 feet. First step, fine motor, draw circle, language, 3 to 4 word sentences, social parallel play, appropriate for age. Dietary history, mixed diet from family pot, family history, no significant family history.
So 3.5-year-old child, how old? So 3.5-year-old child with mother noticed a lump in the abdomen, abdominal swelling on upper left side, 6 months back. Correct? Yeah. No. So when baby was 6 month old, so last for 3 years, this lump is there. Okay. So what are your thoughts? What are your thoughts? First, tell me what is this lump? Spleen. Okay, so spleen is almost sure that it is spleen. Can it be anything else? Left upper abdomen. So what else can it be?
Splenic flexure of colon, mass arising from splenic flexure of colon, adrenal mass, pancreas, mass arising from pancreatic tail, left lobe of liver.
So good, you thought of some other anatomical structures in that area and you gave us masses arising from all of those. Now, between all these, which is less likely and which is more likely?
Colonic less likely because it will be associated with obstruction and GI symptoms. And more likely spleen.
So if this history is right and if this lump is there for the last 3 years, then all the other anatomies which you mentioned of tail of pancreas or colon or any of those histories, those lumps will not survive for 3 years without any other complaints. Okay. So if there are two big ifs, one is that this whole story is 3 years say it's going on. And the second, you said no history, no history, no history means there are no other symptoms. If there are no other symptoms and it's going on for 3 years, then only spleen only is possible. The other things are not possible. Right? Okay. Now you said it progressed to abdominal distension. So you mean to say now whole abdomen is swollen or what is it?
There is whole abdomen is swollen, but more on the left side. That is spleen mostly.
So I can understand that sometimes it's difficult for you to take the accurate history, but what is the thought in our mind? One thought is whether this, suppose it is spleen, whether it has gone on increasing, and now it is occupying almost the whole of abdomen, huge spleen. We are thinking one thing is that, and the other thing is that what started as spleen became hepatosplenomegaly, maybe with ascites. That is our other thought process. We are trying to differentiate between the two. You understand? So that now, importantly, I don't think anything which starts as splenomegaly will later become hepatomegaly with ascites. It can become hepatomegaly, but it will not become ascites. Usually, all the ascites wala conditions will be originally hepatomegaly followed by splenomegaly, right? So, therefore, this must be just a spleen which has got tremendously increased in size. So now tell us, what if it is a spleen which has become very big in size, then you said there are no other symptoms. Would there be any subtle symptoms? All these two you have asked, so there are no other symptoms, right? Would there be any other subtle say? So when there are no other symptoms and when there is a big spleen, what is the thought process? Bleeding manifestation due to big spleen or as a cause of the big spleen? What are your thoughts? Generally, just let's go through the undergraduate list of reasons for spleen and let's take each group and decide. Can it be infection? What do you think?
Infection could not be for 3 years. Infective cause will not persist for 3 years.
There has to be some symptoms of the infection, no? Some fever, some other complaints. So if there are no other complaints, then infection is out. Correct? Then what are the other causes? Can it be a malignancy? If it's a malignancy, what kind of malignancy?
Hematological, leukemia,
Can be leukemia. Not for 3 years, but if we assume that the first mother has not given proper history, then it can be women, or it can be infections like malaria or Kala-Azar or storage disorder also can be the differential.
So I agree, storage disorder is a differential. My point is, see, for leukemia, you have to think like this, that if it is leukemia, obviously it can't stay with only a spleen for 3 years. That is out. But the point is, even if that 3-year history is wrong, leukemia will not present with a lump in abdomen or a spleen as the first complaint. It will come with fever or petechiae or pallor or whatever. And all those things will start happening. So acute leukemia is out. What about other causes, chronic leukemia?
Is there any cause of blood, hematological cause of a very big spleen? You have heard of chronic myeloid leukemia. You can present with a big spleen. The child is not very pale. The counts are abnormal, but the child not very pale. And for such a huge spleen, one of the dig is CML, but there are other 2, 3 causes, out of which some chronic and topic, and then some fibrosis or something of the skin, myelofibrosis. And in myelofibrosis, the bone marrow takes over. These are 4 most important causes. But here the spleen is not so big, so far. So 6 months going on, if a child comes to me by about 1 year or so with a significant splenomegaly, nothing else, I'll still keep extrahepatic portal hypertension in mind. Today he has not bled, but maybe after 1 month or maybe after, usually the spleen is not. Whoever I have seen, most of them are around 3, 4 years. Spleen is moderate. One may or may not give one importance to that spleen, or 2.53 centimeters. Because there is a hematemesis, it brings our attention to the splenomegaly. But that is also to be kept in mind, especially, and it can start occurring in a very young age. That is another thing. So isolated splenomegaly, but I would still keep in mind, it is not possible to say with certainty that there is no associated hepatomegaly as well. I would really think of that. Isolated splenomegaly presenting as abdominal distension in the absence of hepatomegaly is less likely. Even a big spleen, more of either a left-sided swelling or a lump in abdomen, which is going on increasing. But if there was a distension upper abdominal, maybe that there was a prominent splenomegaly, that is why the mother has said that. But I would think that this is splenohepatomegaly in my mind, coming on very early in life and going on increasing progressively without giving rise to any other symptom significant. The child's development, child's pallor, none of those are hematological system is involved. Neurological system is not so far involved. There is no evidence of a chronic liver disease at the moment. So whatever is there is a slowly progressive disease without affecting hepatocyte in the liver. If you say a liver disease, without happening hepatocyte or the cholangy, that means the bile canaliculi. So bile disease, no. Primary hepatic disease, if it is there, must be slow. That means it must be invading the reticuloendothelial tissues, and that is what it is likely to be. So the hepatic failure and those signs have not yet come. So probably splenohepatomegaly, perhaps of a storage origin, because so far the hepatic cell dysfunction has not come, and therefore reticuloendothelial tissue may be involved. To what extent liver is there, I don't know. Otherwise, there is nothing, growth, etc. There is no significant pallor, but we don't know the history. Clinically, there has not been. But if there is a pallor, then our differential changes. So even if there is no complaint, we'll still keep hematological causes in mind. Isolated splenomegaly with hereditary spherocytis, as we keep in mind. Often there is an icterus, and by now many other things would have happened. So if we say no pallor, then probably a storage, hepatomegaly. If we say there is some pallor, then we have to come to a different. And as we said, a huge splenomegaly, those 4 causes are to be kept in mind. Kala-azar and malaria will not keep in mind. The absence of any fever whatsoever. As in only one case of myelofibrosis. Huge spleen, about 4 or 5 year old spine, huge spleen, but I've seen only one.
Sir, I just agree. I just thought that even for hemolytic anemia, them presenting with just a huge lump in abdomen is not a good way or not a common way in which they present. So the pallor has to be much more prominent, so much so that they will complain of pallor. So therefore, I think hemolytic anemia is also out. A lot of people online have given most of the causes. So they have talked of storage disorders, tropical splenomegaly, Kala-Azar, etc. Kala-Azar again, because the child is otherwise no complaint at all, as in no fever, no loss of appetite, loss of weight, nothing. Even that seems less likely. So we are left with storage as a big possibility. CML, as Sir said. I'm still not sure about that 3-year story, as in started at 6 months and still going on for 3 years. I don't know how accurate that is. So we are looking at storage and CML. Yeah.
So can hereditary spherocytosis be considered in this?
That's what I said. One is that hereditary spherocytosis doesn't come with a huge spleen. Secondly, their complaint will not be a lump in abdomen or a progressive splenomegaly. Their complaint may be icterus, as Sir said, or there could be pallor related like tiredness, etc., but not come as a lump as the main complaint. Right?
You say that the pallor has been there for some time and the parents have overlooked that this particular child has pallor. But when you on examine, we always like to relate pallor splenomegaly. But if they have not, if it's going on for so many years and right from the pallor ought to have been there. Even if he's given supplement, this, that. So for long-standing splenomegaly in a hematological disease, yes. Some tests were treated as dengue fever. How did you like that? I mean, I won't say no, it could have been associated dengue fever, but to my mind, no. Perhaps, well, I remember one sentence to which I give a lot of importance, dengue. Abrupt onset of very high fever with headache, body ache, and lethargy. Now, whether there are other things, but almost always it has present as an acute illness and a use spleen, etc. So dengue, no, must have been, I think some IgM, something must have come up positive and given treatment.
One online comment is whether any abnormalities of the portal vein. So yeah, that means it's extrahepatic portal hypertension. But again, means we need to confirm on examination how big the spleen is. But as Karesar said, usually the spleen is not very big. It is either small or moderate. And at that point, the child will bleed. So it will not happen that the spleen just goes on and on increasing, but the child doesn't bleed. That is an unlikely uh, possibility in EHPVO. So beyond a certain point of size, we don't take EHPVO into consideration.
Splenomegaly because it's extrahepatic usually.
Come, we'll just see the child. लेके आओ उसको. You have that cot-like thing to make him lie down.
What storage likely? Carbohydrate, fat, is that gone? Lot of storage has to be there. One thinks of Niemann-Pick where splenohepatomegaly is more prominent. There are different varieties of that, and sometimes you may not get neurological affection as early as that. मराठी कळतं? चला, तुझं नाव काय? नाव काय तुझं? वाह, शेक हँड कर. गुड बॉय. छान आहेस ना तू?
On inspection, the growth look it's looking Growth is growth is looking appropriate for age. Child is active.
So after our discussion on history, we were discussing what as the main points. And we were given a history that it started at 6 months of age. So for a storage disorder which started at 6 months of age and is there for the last 3 years, growth is appropriate tells you what?
Mostly cannot be a storage disorder. It will affect growth. On head-to-toe examine,
You said growth, then what else? Sick or not sick?
non-sick,
Not sick. Pallor, icterus, edema, can you see anything?
no significant pallor, no icterus, no clubbing. Slight abdominal distension present on left side, not that significant. Umbilicus is inverted only.
Hemolytic,
No. Bossing. Frontal bossing is there, but
so no hemolytic phases. Okay. Shall now feel the palpate the spleen.
When we started taking him in our labs, that is the time they found that there was some lump on the left side. So right at 6 months when they started, it's true that going on from 6 months. Yeah, much earlier.
we can see a lump on the left side of the abdomen, upper left.
I can see a lump here, and I can see a depression here, and I can see another lump. So this is a rib cage, lower end of rib cage. There's nothing much there, and this is almost here. So can you appreciate that?
Hmm.
It is moving with rest. Now further analysis whether it is moving posterior direction or up and down. So in connection with diaphragm or otherwise. Can it be renal lump? They will move with that. And I can see some depression there. So we can insinuate our finger there. Okay. Yeah. So it will come from here. The more projection will be anteriorly, and it has to be a really, really big renal lump for last 6 months to occur. But this is just to keep in mind that renal lumps can present. They can be less hypochondriac and more on the midline and left side.
The spleen is palpable, almost 5 to 6 centimeter. This consistency. Liver is not non-tender. Yes, sir. Left lobe is also not palpable.
The little is palpable of the liver. Were you able to judge the consistency and the firmness?
No, sir.
The contracted liver of a cirrhosis, congenital hepatic fibrosis, etc. You expect the change in the consistency. So, what is your comment on the consistency of it? जरा कर असं कर रे बाळा नाव काय त्याचं प्रियांश असं कर It's just for me to get an idea of the surface and consistency. What is your comment on consistency?
Any other, you have any other findings besides this?
No. This. 1 centimeter liver, and there is a around 5 centimeter non-tender spleen with right lobe. Just just
You have to
palpable.
really make it one sense. Mainly, what about the consistency, the firmness of the liver? Will you call it hard, firm, soft?
Soft.
It's soft to firm, but you may be justifying call it firm. What I mean is this the primary liver problem or no is what we are trying to judge.
Also, the history that you said that it has become generalized abdominal distension. So we were assuming massive splenomegaly or spleno with hepato, but it is not generalized abdominal distension. It is left side only. So that history kind of makes us assume wrong things. So now ultimately it is just a lump in the left side which was noticed in 6 months and which has remained 3 years. So it is a moderate splenomegaly, not a massive splenomegaly, without any big hepatomegaly, without any fluid in the abdomen. So now what are your thoughts? What could be the possibilities? Some things have changed from the history that we were discussing. We were discussing massive splenomegaly. It's not massive. And there's no hepatomegaly. So now what could it be? Do you think it could still be hereditary spherocytosis? Why not?
There is no significant pallor, and spleen is also around 4 to 5 centimeter. Also, there is no history of transfusion also in the past in 3 years. There is no icterus also.
Parents?
So see, hereditary spherocytosis may never need a transfusion. So no transfusion does not mean no hereditary spherocytosis. And icterus is usually there, but again, icterus may be mild or the bilirubin level may be mild, not enough to show you icterus, right? Pallor you can mistake as in there is some pallor and it's anyway hereditary is not deep pallor. So it becomes difficult to say yes or no. So one way is to check if parents are short in height and if they also have a spleen. Then in the exam you can be very, you can get plus marks by saying that I look for the spleen in the parent. Okay, if it is hereditary spherocytosis you're thinking of. Then what else?
Failure for the child.
What else could it be or could it not be? So now can it be EHPVO because it's just moderate size spleen? It can be. It can be EHPVO also. Can it be leukemia lymphoma? Why not?
Other complaints like fever, bone pain, sweating, and child is active, no non-sick child, and long duration symptoms like 3 years. Leukemia could have presented earlier.
Can it be CML? It has not become massive, but it is on the way to becoming massive. After 1 year, 2 years, it will become massive.
CML too early to start at the age of 6 months. CML. Starting from the age of 6 months, it's too early. Should have presented later.
That is one, and even then, for 3 years, there should be some complaint somewhere else, some fevers, this, that, not just that the spleen will be big and no other complaint is unlikely. Then even the consistency, what is the consistency of this spleen? It's very firm. So very firm is again like as if it is infiltrated with something like that. So leukemia spleens are not that firm. Okay, fine. So come now, what will be your final diagnosis?
Can it be a splenic tumor? Local pathology. Possible one has not seen is the thing. That's why we don't entertain. Which splenic tumor, if you ask me, I have to scratch my head. But just keep it at the back of your own local pathology. Only one investigation is permitted.
Year 5-month-old boy, second by birth order, born out of non-consensuous marriage, complain of abdominal swelling in left upper quadrant, which is progressive in nature, not associated fever, pain, jaundice, bleeding manifestation, edema elsewhere, in normal ANC per developmentally appropriate in well immunized child. In immunized child, case of abdominal swelling, most likely organomegaly. Differentials will be extrahepatic portal vein obstruction and storage disorder. General examination. General condition is fair febrile, heart rate 125 per minute, pulse regular, good volume, respiratory rate 25 per minute, peripheral pulses well felt, extremities warm, and throw is normal child. Weight is 12.5 kg, height 99 centimeter, mid palm circumference 13 centimeter, head circumference 46 centimeter, weight for height is 0 standard deviation. Little bit short. No, yeah, short. Mild pallor is present, no icterus, no cyanosis, clubbing, lymphadenopathy, edema, no dilated veins, no abnormal faces, normal spine and genitalia, normal dentition. On per abdominal examination, inspection of globular abdomen, no dilated veins, scar or sinuses, flank appears normal. On palpation, inspected findings are confirmed. Liver 1 centimeter soft, just palpable. Spleen 5 centimeter from left subcostal margin. Firm in consistency, like it's grade 3. Percussion, no evidence of free fluid. Auscultation, vowel sounds normal. CNS wise normal. CVS, no murmur. S1 is 2 present. Chest is clear. Air entry bilateral equal. Uh, 3 year, 5-month-old boy, second by birth order, born out of non-consensual marriage. Complaints of abdominal swelling in upper quadrant, which is progressive in nature, not associated fever, pain, jaundice, bleeding manifestation, edema elsewhere. In normal ANC birth, developmentally appropriate in immunized child with Acquet's grade 3. Firm spleen with no dysmorphic faces is a case of splenomegaly under evaluation, which is most likely EHPVO.
So on examination, was there any point which made you remove the storage as a differential?
Developmentally normal and no dysmorphic faces.
Not compulsory that they should be developmentally affected. Dysmorphic faces is again more about chromosomal disorders. So at the most, we could have argued about growth failure, that if there is no growth failure, less likely to be storage.
On investigations, these are the investigation. Uh, 8 October, the child with hemoglobin 8.9, hematocrit 30.6, WBC 7,400, platelet 1.8, 185,000. Now the child came with HB of 9.5, hematocrit 34.1, WBC count 7,000, with platelet 1,56,000. PTINR was 15.8 and 1.31, OTVT 12 and 21, total protein albumin 6.44.1, RFT 16.6. USG were done on 30th Jan 2025. It's suggestive of portal cavernema, mild splenomegaly, and pseudo thickening of gallbladder. On 16 March 25, moderate splenomegaly, acalculous cholecystitis, and mesenteric lymphadenitis. USG on 22 April, suggestive of mild splenomegaly with periportal, collateral with portal cavernoma formation. CECT done with portal vein replaced by multiple collateral, splenic vein replaced by multiple collateral, multiple periportal, perisplenic, perirectal, aortocaval collaterals, few collaterals seen in submucosa of rectum.
So you proved a diagnosis of EHPVO. Now, what else? Have you looked for any varices? So, not yet done. Okay. How do you explain his CBCs? How will you interpret or think of those CBCs? Anybody? Just now said the previous child was HUS. So why this is also not HUS? There is no 1.05 thrombocytopenia and hemoglobin 7.7. So you've got both hemolytic anemia and thrombocytopenia. So this is also HUS. Simple, but I want you all to start speaking right from your early posts so that you learn. Tell me, you know the answer. Tell me why it's not HUS.
Next is 1,56,000 with hypersplenism. Uh,
Severe anemia and hemorrhage.
Have you confirmed the platelet reports from a smear?
It, small platelets considered as WBCs.
I don't know why you're finding it so difficult. What is the definition of HUS? What all should be there in HUS? First thing should be anemia. Any anemia? Iron deficiency anemia. HUS. What is the word? Hemolytic anemia. So beta thalassemia, HUS. So what is the word before hemolytic anemia? So microangiopathic hemolytic anemia is the first requirement. So every anemia need not be microangiopathic hemolytic, no. So where you have proved that this middle wala is microangiopathic hemolytic, you have not proved yet. How do you know it's microangiopathic? What tells you it is microangiopathic? Peripheral smear showing cystocytes, which that earlier one case did. Okay. How do you know it is hemolytic? The retic and the LDH was high. So this doesn't tell you all that. So there's no question. Second requirement is of HUS is thrombocytopenia, and third is acute kidney injury. Where is acute kidney injury? Point is, just you show a CBC with pallor and thrombocytopenia doesn't mean HUS, no? Okay, fine. Now, you said hypersplenism. So, it is possible that this is due to hypersplenism, or it could be due to deficiency anemia also. Platelets may be due to hypersplenism. So, how will you make out whether this is deficiency anemia or due to hypersplenism? Very good. You have to look at indices. So always make it a habit to put up the indices also, so that we all interpret, so that we learn and it becomes a habit. So deficiency anemia will be microcytic hypochromic, whereas hypersplenism will be normocytic. And they are asking about RDW also, right? So all that is important. Fine. How will you treat this child? Scopy is for varices. So what will you do? If you find varices, what will you do?
If there is a bleeding manifestation of your step. Ligation.
What will you do to that original cause? The portal cavernoma and also many collaterals are there. Will you do something there?
Shunt procedure.
Very good. Shunt. So when will you do the shunt? When as in, will you do it now? So what decides whether you should do a shunt or not?
Compensated.
Very good. By which you mean what? Compensated means what are you trying to say? You're right.
Of decompensation like ascites, um, variceal bleed, then CNS involvement is not there.
CNS and ascites we are not expecting also. We are only expecting variceal bleed. So you're right. So far this child has not bled. So you will look at the varices, maybe ligate them and wait. If a child keeps on bleeding again and again with the varices, then you have to divert the flow because it's going on happening again and again. That is when you use a shunt. So what does a shunt do? It diverts the flow and reduces the pressure in this circulation, right? So that is the logic. Okay. Plus, don't forget the general supportive treatment. So iron and B12 and folic acid and vitamin D and all that.
Do you keep the spleen, remove the spleen? Such a big spleen. Injury, the size of spleen itself can be an indication for surgery. Huge spleen in a child. Would you conserve the spleen, remove the spleen? What is your plan? Huh? We will try and conserve. Removing a spleen is a very big decision. And 30 years and 50 years later also they can die of fulminating sepsis. So try and preserve this as far as possible.
Fine. Any questions? Online, any questions, any comments?
It's an absolute pleasure, Rajesh, to be present at such sessions. Two unusual cases. Wonderfully presented.
We are also learning every time. Thank you so much.
Thank you.
Okay. Thank you, everyone. So we meet next Thursday at 5 p.m. Thank you.